and I'll flick over to the agenda for today. So this is just a reminder of obviously how to conduct ourselves in this call, but we've all been on a few of these now, so I'm sure we're aware of what we need to be doing. So the agenda we're looking through, we've got a quick spotlight on one of the dashboard features for today. Hopefully this will become a bit of a running item in these meetings, just to obviously, as you're getting to know the dashboard, we can draw your attention to certain features, and then yeah, it might act as a refresher for some of you as well. Then today's topic, we'll be doing a conversation with, so we've got colleagues on the call who have started their implementation journey within their PCN, so they're very kindly offered to answer a few questions in a sort of Q&A style session where we will learn a bit about what they're doing, and we can dip into that shortly. Then the activity will be sort of taking the learnings from that conversation. You'll sort of break down into groups and have a think about how you'll be planning your own implementation. So there's a few prompt questions, and there'll be a Miro board, which hopefully you'll be able to contribute to. So the link will appear in the chat around that time, so just keep a lookout for that, and we can use that for the activity, and then just any other business at the end, we can pick that up as and when. So if you've got something you'd like to address, then keep that in mind. So the first item, then, the dashboard spotlight. We wanted to draw specific attention to the demographic filters that are included in the dashboard. So I've got a screenshot here which you are hopefully familiar with at this point. This is what the hypertension page, the hypertension tab of the dashboard looks like. So you can see you've got the sort of 4 main boxes here with various sort of subheadings, and these bars you can click in a customizable fashion, and that will then dictate what patients show up in the corresponding patient list at the bottom of the page once you click the Show Patients button. But there's also this additional set of filters at the bottom under the Show Demographics button. So you'll click that, and what happens is you'll get this set of additional filters that appear at the bottom. So you can see now where it says Hide Demographics and Patient List. This is slightly further down the page. I wasn't able to fit it all into the one screenshot, but you can then further customize the list of patients that you're hoping to generate. So you've obviously chosen all of the clinical components. Then here you can break it down further by demographics. So we've obviously got gender, age, ethnicity, and then we've included deprivation based off IMD quintile, and SMI and learning disability as well. So obviously the ambition here is you're able to really drill down into the populations that you're hoping to target and manage. And even you could use this as a bit of a data viewer. So while you're selecting the clinical components at the top of the dashboard, you can then observe at a sort of overview the breakdown into each of these categories and filters. And then obviously if you want to generate patient lists, what you'll do is just again further select the bars that you are hoping to include in the patient list. And then again, the screenshot was quite large, so I couldn't include it, but you can see at the very bottom that then generates the patient list that you're able to see, and you can export those that list as normal, just either as a CSV or like a PDF screenshot. So the export functionality is still the same, but there's an additional layer of customization that you're able to put on top of the data that's already available. Does anyone have any specific questions about that element of the dashboard? Hopefully it feels quite straightforward. And we do have, if you don't currently have access to the dashboard yourself, then we do have the dummy dashboard that we're able to share a link to. So if you either don't have one yourself or don't have the dummy dashboard link, then please let us know and we can circulate that. And while you're waiting for the access to your own data, you can sort of have a play around with the functionality of the dashboard, including the filters and other such things. Brilliant. That's the first item. Then we'll move on to the conversation with. So, oh, thank you, Laura. You just dropped the link to the dummy dashboard into the chat. Yeah, so as I said, we've been joined here today by Deep and Romil. I'll ask them to introduce themselves shortly, but they're from a PCN in Northwest London who have started their implementation journey. So the dashboard is currently available through their public health management system called Wizit, which is available locally. And they've had access to the dashboard for a couple of weeks now, so we're hoping just to ask a few questions about sort of any planning that was done beforehand, and then sort of current experience and planning. So I'll ask you to introduce yourself. Rommel, could you go first?
Hi, so I'm Romil. I'm a pharmacist at Hammersmith Fulham Partnership. I'm also the CVD lead, and I'm based at one of the surgeries, which is Park Medical Centre. Yep.
Thank you. And Deep?
Yeah, so Deep Shah, GP, also at Hammersmith Fulham Partnership. I'm based at a different surgery to Romil, but work with him. There'll be another GP also working with Romil as well.
Great, thank you. So I'll dive straight into the questions, and we'll do this for a bit, and then people listening in, if you do feel like you have questions as you go, please feel free to put them in the chat, and then once we've concluded this bit, we'll go to the audience for sort of wider questions. So yeah, either hold on to them or put them in the chat as you go, and we'll do that at the end. So now, first question, what planning and preparation did you do before you actually gained access to the dashboard?
So I think we did majority of our process implementation before we even had access to the data, in terms of how it's going to work, who is going to be triaging and where they'll be triaged to. So I think that was all dealt with before. I also met with, we have CVD pharmacists on each site, so I'd met with them individually, and we went through the dummy dashboard. And what the actual idea of CVD Action is. So they've got that. So like what the point of doing this project is, and I think we also went through it in our CVD cardiology meeting with all the GPs that are in that work in cardiology, as well as the nurses and pharmacists beforehand too. And I think the whole pathway was pretty much planned beforehand, as well as what members will be involved and roles and responsibilities. So I think once we had access to the dashboard, it was just a matter of going full steam ahead. Don't know if Deep wants to add anything else.
Yeah, thanks, Romel. So really, I think that's the key, really. So we looked at each of our sites and really looked at the information that which staff member would need what. So we decided that on each site, the pharmacist would be doing the majority of the review. So we had identified a CVD pharmacist each site who would be running this. We talked about setting up clinics or setting up slots for them for each clinic. So CVD clinics or CVD Action clinics for each specific site. And then the other thing we did was really establish a pathway within the sites to make sure that there's a kind of a chain of command. So if you've got a pharmacist who's got a question, then who they will be approaching. So that was really the initial part of the work. And then we also decided in terms of the framework of, so Romil is running the project, and what he didn't mention was that he would be doing an initial kind of desktop reviews of the patients, and also be looking at the numbers of patients and keeping a track of how the project would be running. So he would be part of that. And then we've also discussed, the admin team and how they'd be fitting in for recalls and that sort of thing. So the idea really was kind of just making sure each of the sites has responsibility for the reviews, but then we're kind of running over a project and overseeing that that's happening and tackling issues as they arise.
Great, thank you. Yeah, it's interesting to hear you've obviously done a lot of the planning, like front loaded in preparation for access to the dashboard. I think important as well, Romo, you highlighted the that sort of wider buy-in across the PCN. It sounds like you've met with a myriad of staff across the practices and PCN to make sure they all understand what we're doing and how it works. I think that's very important as well. Thank you. Next question then, how did you decide what specific cohorts of patients you were going to be working with?
So I mean, we knew we were going to tackle hypertension and cholesterol initially, so we just thought go for the high risk patients first. So in hypertension, it would be anyone that's not managed. They've got a blood pressure of above 160 on record, as well as cholesterol. So previous CVD event that are not on lipid lowering therapy, and we thought combine both of those searches to identify people that meet both cohorts. So those are really high risk, so we can tackle them first and then work our way down. That was essentially it.
Yeah, just just to add to that, so I think absolutely we looked at poorly controlled hypertension and cholesterol, and then the thing we were trying to manage was not having huge lists of patients. And what we realized quite early on is that if we're picking out patients with cardiovascular disease, not on lipid-lowering therapy, also with poor hypertension control, then that gives us a manageable list to start running with initially. So the way the dashboard works is it actually helps you identify those patients, which was really helpful.
Great, thank you. That's really useful to understand. The next question then, so I think you've sort of touched on this already, but what are your plans now for optimizing the patients, and how have you decided what staff members would be involved in that process?
So I think we mentioned that we would have a CVD pharmacist that would be per site, and they'll be supported by the CVD GP. We will just be recalling patients to them based on the searches that we've identified, and after doing a desktop review, so they'll pretty much will just see notes or have a look at that, and they'll know what to do based on that. And then naturally, once someone's into the system, they'll just be followed up by that clinician. So that's how we decided an admin team where we needed someone from admin to actually help us recall the patients in. So I think that was a pretty straightforward process. Yeah.
Great, thank you. Next question then, how have you interacted with the dashboard so far? So have you used things like the demographic filters that we've just sort of highlighted, and some of the other features as well? And obviously you've said you're focusing on lipids and hypertension, but have you sort of made considerations for the wider elements of the dashboard?
I'll be honest, I've not really used the demographic bits yet. I've been using the CKD stuff for QOF, so I found that quite helpful. It was a cheeky way of just quickly looking at QOF, so that's what I've been using it for, because I just have a look on the side and it just tells you exactly what you're missing, as opposed to the individual QOF searches where you have to go for each clinical condition. But I've not used the demographics yet. Don't know, Deep, if you have.
I did, just because you know, one of the things you mentioned initially was that the desktop reviews are for the younger patients were more straightforward, and you felt that they should really be booked in almost directly. So I was playing around and seeing, you know, the demographics and seeing what cohort of patients could you pass directly to the recall team to book in, and then you might have a second list of patients that you want to do a more detailed desktop review before you book them in.
Great, thank you. That's a useful example actually of using that additional stratification filtering to be able to then streamline the workload and the processes as well. How are you ensuring that these new ways of working and the new pathway reflects the needs of the patients that you're caring for?
I mean, you're kind of, it's a bit of, I mean, this work that probably may have not been done because it's proactive work. So I would say indirectly you are meeting a need. You're preventing, trying to prevent cardiovascular disease, which might have not been done before, because this proactive work is probably not happening. So I guess in that way you are, you know, meeting their needs. And it's also an opportunity for people to, you know, once they're in the system, they would naturally have questions, or they would want to take matters of their own health, you know, into their own hands. And normally I find people just don't want, you know, some patients, until they're actually booked in or recalled, that's an opportunity for them to say what their needs are. So that's what I'd say just by, you know, proactively getting those patients in, we are kind of meeting that. Don't know if Deep's got a different view, but that's what I think.
Yeah, so I think for me, you know, it's almost, one thing was reassuring that we don't have significant amount of patients on having, you know, the care that they should be having. It's not having the care they should be having. So, you know, the lipid lowering therapy on cardiovascular disease example. So we have about 80 patients that are at our practice who are not on the correct therapy, and, you know, identifying these patients early on proactively means that actually you can offer them that treatment, but actually what we're obviously not doing is doing that during the routine clinical care. Now, there's lots of good reasons why these patients are not on it, but this is affords them a review to ensure that actually they offer the treatment and that they don't need it, or they need something alternative. So it's a nice way to ensure that you're picking out the patients who need that care quite early on, and it's being more proactive. And with hypertension, if someone's got a coded blood pressure of 180, then really, do you have a plan in place? And most of the patients we've looked at do have a plan in place, but offers the opportunity just to make sure that review's in and that safety net's been built in as we're going through these patients.
Great, thank you. I think that leads on nicely actually to the next question around the use of partners' proactive care framework approach. So have you had a chance to incorporate any of the wider resources into this planning? So things that support the self-management, behaviour change and education for staff and patients?
Shall I take this one initially, Romeo? Yeah. So the short answer is yes, but the long answer is that because we're just starting the reviews as we're going through this, then we're going to start involving some of this. So we've looked at some of the resources and we're going to start socializing it. But formally, I think the first set of reviews are happening over the next week or two. So then it's an opportunity to actually involve the patients with that information and actually ensuring that the healthcare assistants and the follow-up teams all have that information in place. But yes, basically.
Great, that's good to hear. Last couple of questions then. So how did your colleagues react when you shared the dashboard with them? So have you done that wider piece, sharing the views and the extracts, and what was the feedback?
I mean, the colleagues that have got access to the dashboard, they do find it useful just because of, you can, for example, that combining of searches is quite useful because it helps you identify a couple of issues that you can just target in one appointment that previously maybe would have taken 2 or 3 appointments to do or identify. And when I did show people the examples of the dummy dashboard, they did find it pretty interesting. So they thought it was a good idea. So they did react positively. And the demographic bit was quite good, as some were quite interested in looking at the, certain minorities as well, health inequality. So that bit was interesting. So,
for me, I think the really nice feedback was one of the other site leads was we just wanted the list of patients because we couldn't see, across all the PCN. And, I asked one of the GPs, can you give me this list? I think she said, I don't know how to do this. And we walked her 3-4 steps and she was like, that was quite easy to get that list. So quite really helpful feedback actually in terms of the ease of use, identify the patients, and the ease of use was it has been positive.
Great. That's really positive feedback to hear. Thank you. And then lastly, do you have any advice for colleagues just starting out with CVD Action?
I think Deep, do you want to take that one?
Yeah, I think for us it's about we like just planning it to make sure that everyone knows what's happening. So across the sites, what they're expecting, and also making sure that there's a policy in place for how to escalate this. So I raised it at a couple of our PCN meetings so that all the practices are aware, and we have an operations meeting next week, so it's on the agenda because that's really when the reviews are starting. So all the site GPs are aware, the site pharmacists are aware, and you don't get patients turning up or being reviewed and not know what's going on. So that people should be aware, and there should be policy, a proper policy in place for who's managing what.
Great. Thank you very much, both of you, for that. That's the end of the planned questions that we had, but I don't know if anyone had anything specifically they wanted to ask, either directly, you can put your hand up, or if you just want to pop it in the chat, for Deep and Rommel about their experience. Laura?
I guess it was the kind of unexpected. Was there anything unexpected that you found, any unexpected benefits or nasty surprises, or anything that you just didn't predict?
Romeo, you want to go first?
I wouldn't say nasty surprises, but I would say it was interesting what Deep was talking about the demographic, about which patients might need a bit more support than others. That part was quite interesting, which we wouldn't have identified previously if we didn't actually do this work. And it was mainly the elderly cohort might need a bit more support, and the fact that you can actually identify them through the CVD action was just useful. So that wasn't unexpected, but it was a good eye-opening thing that I thought was quite useful.
Great, thank you. Matt.
Thank you. Sorry, struggling to click the right buttons. Rommel, yesterday we talked about this idea of accelerated progression. Deep, you and I have discussed this before, but I know it's very early and you're just starting, but is there anything you could say about this, about how you think you might approach this? So the idea that we see someone, we start them off on treatment, we'll see you in a month and see how we're getting on. Actually, we don't need to wait that long. We could accelerate hypertension treatment particularly much more quickly than that. So is that something, how do you feel you might build that into your pathways?
So I think, Matt, as I mentioned yesterday, I think biggest problem, well, typically is clinical inertia. So I do agree with that. I think that comes a bit to education for patients. I think we could use this opportunity to, well, as I've done in, just by triaging some of these patients into clinics, it's just getting them in charge of their own health and, letting them know what their targets are, that they themselves can kind of optimize it. And I think this is a good opportunity to just use that education side of things. If it's uncontrolled, then just, they can increase it themselves, and then I'll see you in a couple of weeks' time, as opposed to a month or 2 months and waiting 3 months before we actually do anything about it. So,
And just to add to that, I think the other thing we've talked about is really building these clinics, regularly over the next week. So it's an opportunity to put the follow-ups in place more formally as you did that, because we're going to have a regular slot for the pharmacists every week to run these clinics, and there'll be an opportunity in those clinics to build your follow-ups in. So potentially it's easy enough to book someone in a couple of weeks. I'll call you. Can I please have a telephone, with your a text message with your up-to-date blood pressure? So we've got some up-to-date information, and that's what we're hoping to do. Hopefully that means wider blood pressure treatment is more aggressive, but actually also more optimized, so that then this is a model that will take beyond that, just not for newly diagnosed and everything else, that to make sure that actually we are this is the model we're following. So that's something we've discussed. The other thing really to mention about this is actually that the other thing Rommel is doing is keeping an eye on all the patients, and it's worth just saying that there will be a feedback mechanism. So if you've got someone who's got poorly controlled hypertension, then Rommel might just get an email or an alert from the GP saying I've done, or from the pharmacist saying I've done this. So we've got someone else looking at this data, but that'll be specific for this project.
Great, thank you, Deep. That's really helpful to understand. Does anyone have any other questions specifically before Deep and Rommel? We move on. Kath.
Thank you. And I'm not sure whether it's a question that you'll be able to answer for us, but here in Bradford, we are just about to start with one of our PCNs. And something that's been going around and keeps coming back to us is about the whole DPIA or the DSA, and how our data's shared and everything. We still keep going back to that. I just wondered if you had any experience of that, or how you manage that data sharing, please.
So I think we were quite lucky in Northwest London. The platform been hosted by WISIC, and the data sharing agreements have come through them. So we haven't had significant issues with that. We just had to make sure we've given access to the correct team members, which can be a bit painful, but actually I think we've organised that quite well. So we haven't come across significant issue because of that. I'm not sure I can add much more to that, unfortunately.
Thank you.
Thanks, Kath. Yeah, so just for clarification, WISIC is the population health management platform that sort of predates this project in Northwest London. So all of the PCNs were already sort of onboarded with that, and all of the relevant agreements were in place. So as we started working this up with the ICB, and that was the preferred approach to deploy the dashboard, I think we were sort of able to piggyback off of pre-existing agreements that were in place. So it meant that we didn't have to invent anything new, luckily.
Kath, if I can come in, I think Mid and South Essex maybe have a more similar setup. So Julia's had a chat with them to understand what they have in place and brought that to a meeting we had last week. So we can revisit that or connect you directly with them if that's helpful.
Thank you. That'd be great, Laura. Thanks.
Thank you, Laura. Yasmin, you dropped a couple of questions into the chat, which we can run through now. So the first one, how do we turn searches into System 1 actions on population level?
Yeah, so we literally just got our access and we were reviewing it. And obviously it's fantastic, but we just didn't work out how to translate that easily into System 1. And I think we discussed it before, that may be a feature that's coming, but how have you guys managed that? So there's like 1,000 patients that need to have a Q risk, for example, but then, you know, I don't think anyone can do that on a search and automate it. But is there anything that you've come up with to make it better at scale rather than individual actions per patient? Because that will become very time consuming.
Shall I take some of that? So the short answer is no, it's difficult, but it's become slightly easier because we're looking at specific cohorts at one go. So we're looking at only the poorly controlled hypertensions and with CVD on lipid lowering therapy. So the numbers are significantly smaller, and that's been easy to manage. The dashboard does give NHS numbers, so that's one way where we have been using to try and translate it into System 1. But beyond that, no, it is each of them. And one of the reasons we've not looked at the Q risk ones is purely because of the numbers. But the other numbers are slightly more manageable, and you can translate them across. But at the moment, there isn't you can't click on a patient and move directly to the System 1 record, which would be ideal.
And is there any sort of thing like, can we export Excel spreadsheets with sufficient data that we can create flurries? Can we do that so we can at least upload back to the system and do text out? Is that something that you think is doable? Maybe. So
we've been creating Excel spreadsheets from the data. That's not been difficult to do. That will have the name, the NHS number. So that's easy enough to do, and that will give you enough data to use in your clinical system.
But is it enough data that we can create an AccuRx message out from it? Have you seen if it's suitable? Does it give you mobile numbers? I'm assuming no, isn't it?
No. Name and date of birth, and I think there's an NHS number.
And to my other little questions, so we had a look, and it's asking us to think about statin doses being at maximum dosage, and we had a few patients and they're extremely frail and don't need those doses. Did you have to do some sort of back coding or to make the data more useful? Did you have to go into your each record and add some exclusion codes to make the data more useful?
So I've looked at some of these patients. I know that they haven't been excluded for lots of reasons. So they haven't excluded patients who've had even a code for statin, statin contraindicated. And I can let Matt come back in on that. But effectively, the desktop review we're doing is looking at these patients, and then we would, if we feel that they're not warranted a review or they don't need that specific therapy, then we're coding them. We've also agreed a code within our PCM, which we can use to make sure that we know that the patient has been reviewed, using this criteria. So that specific code we know, not using for anything else, and that we can search on that and know that this patient's been reviewed and exclude them kind of from the future as well.
And then maybe for Harry, do we have the list of codes that you're using for the dashboard? So we're using the right exclusion codes because there's so many of them, as I'm sure you're aware. So if we are coding to improve the quality of the data, that it shows on the other end of the dashboard when it reloads.
Yeah, absolutely. We've got the list of codes used, and I'm sure I'm getting a nod from Laura, so I'm sure we can be sharing that. I don't know, Matt, if you just want to come in on this topic.
Yeah, it's a really important question, and I think the first thing is that coding in general practice is not perfect, as you know, and one of the challenges, if we look at statins in particular, is that a lot of people are coded as not being suitable for statins or whatever, and then that's the end of the story. They never get offered that again. Some of those patients will not be suitable for statins, but it's probable, and I think there's research evidence to show that quite a lot of them will be suitable for statins. It's just they're not being able to have the proper conversation and support to do it. So we have that on the one hand, and on the other hand, we have about 1 in 6 people with cardiovascular disease are not on any lipid lowering therapy, so it's significantly high risk. So we will prevent some heart attacks and strokes by finding those people who are not on statins, some of whom have been coded inappropriately. It's a complex thing to solve just by going with data and coding. And I think that's the conclusion we reach with CVDACTION. We can't solve all of this. So we end up with a group of patients who need further assessment. I think that's what it's saying. Some of those will be frail and won't need a higher dose. Some won't be tolerant and won't be suitable for it, and some will. And some of that information you could work out through desktop review. And some will need face-to-face or voice-to-voice discussion with the clinician. But so we've identified a problem that we cannot solve just with the data that's available. This is trying to make it easier to solve. And one of the objectives with CVDACTION is to try and create manageable chunks of work from really big chunks of work. And so you can, for example, just select individual populations you're going to start with. So your patients with both hypertension and CVD who are not on lipid-lowering therapy, relatively small numbers. So that helps you to work through in some sort of priority order. So it's a bit of a different approach, but it's acknowledging that the data is not good enough, the coding is not good enough to help us here. Does that help, Yasmin?
I think so, yeah. I think if we could have the list of codes, so when we are going through each case one by one, we do have the right codes. Is there a template on system 1 which matches the codes on the data that we're using to output into this dashboard? So when we're doing our reviews, is there such a template? If not, can we quickly put one together so we can make sure it's all matching? Because it will definitely help you guys know what we've done as well if we're using the right codes. So having a list of codes on a piece of paper is always helpful, but maybe having a...
We can provide the codes. We've used the standard... Sorry to cut across. It's the standard code sets we've used that are used for CVD Prevent and QOF. So they're published and ready available, and we've just drawn on those. I'm not a System 1 user. I don't know what templates are available. Deep, do you have insight into that?
No, we're not using any templates at the moment for this. I think we're just doing a clinical review, but we can look at setting them up actually over the next few weeks.
Yeah, I think part of it, Yasmin, is acknowledging that through this demonstrator period, this is the sort of learning we have to build and understand. What is this helping us to do, and how could we improve it in the future? And that's going to take some time. But it's great to get your thinking on this, because that's going to evolve how help us evolve the tool as we move forward.
Thank you, to help. And the only other question, I guess, is when we look at it, there are obvious things that we could do better, like urine ACRs. We're not getting the CKD, and maybe we're not doing enough AF screens. I guess that's the data we need to make the dashboard even more useful, because then we'll hopefully be picking up more and we can make better decisions. So in terms of order or like quick wins, when we're rolling this out, because we're right at the beginning, what would you guys advise? I don't know if it's Park Medical that want to advise. Where do we start, really? We're just about to start as a team.
So Deep and Romy want to come in, as they've given quite a lot of thought locally, but I guess one of the purposes here is to acknowledge that there are lots of important things to do, but then lay it out in a way that we can actually make clinically sensible decisions and choose priorities. From our evaluation perspective, we've asked people to focus on blood pressure that's poorly optimized, and people with CVD not on statins, lipid-lowering therapy as a starting point, because they are high priority and because the numbers are big. And if we sort that out, we'll have a big population health impact quite early. But locally, there'll be other things in there that you would decide, you would think this is also important, CKD and diabetes, for example. But Deep and Rommel, have you thought about that, about other than the BP and lipids that you feel are local priorities?
So I think something big in Northwest London at the moment is CKD. So that's something that we are trying to do, because it's a big push at the moment within the community, as well as the secondary care team. I think Northwest London is one of the worst for CKD management. So it's something that we are working on. So that would probably be something we are going to be looking at alongside hypertension and cholesterol.
Great, thank you very much for clearing those questions up. Lastly, then we've got a question from Nigel around could we set up to download the filter searches onto our system? Sometimes we need sub searches to unpick patient disease outside of CVD Action. You want to expand on that, Nigel? What would you mean by filter searches? Sorry.
Well, the searches you prepared are really good, but it's restricted to a search that you've built, looking at those 5-6 domains of illness. Sometimes as we work through this, what I'm thinking is we're going to find ourselves doing a lot of work for people, and themes may emerge as to why the patient's not optimized. So we want to have a strategy to deal with the volumes first, and then going into the more difficult and more challenging areas later. So it may be much easier if we had your searches copied onto our systems, and then we could build sub-searches to exclude various groups of people whom are emerging as a group more challenging to deal with, and set those up as a separate work stream, which are going to take more time, more effort, more energy than other individuals who are more straightforward. We've got many comorbidities, mental health illness, heart failure, 101 things, which may influence whether people readily fit into a cardiac uni disease management plan. So if we had those searches downloaded onto our system, it would then be easier to do filters and set work streams up as rapid patient throughput or slower patient throughput, and allocate people's times accordingly, and allocate our expectations of how many people they can get through accordingly, start thinking in terms of groups, like if there's a problem getting mentally ill people engaged with more medication for cardiac management, how to gather that data and put it to one side so we can have discussions as to how maybe we can encourage them to be engaged more. So I appreciate we're focusing on cardiac disease and cardiac disease prevention and early intervention, but we're dealing with a very highly heterogeneous population with so many nuances and so many inbuilt characteristics, some of which we can pull, some of which may be impossible to pull. But having the search on our system would allow us to individualise it according to what our needs are in Brent and what our common themes are in Brent, which may or may not be similar to Hammersmith and Fulham. There might be overlap, but there might be very different population sets.
Actually, that's something that came up in our discussion we had earlier with Neil. Actually, how are you going to translate this data into actions is the everything, isn't it? So an Excel spreadsheet only does so much, but if the searches were already in system one, like the key ones, then we could use a dashboard to direct us to those searches as well, and run things like we can do bulk actions, which I think is so important in terms of time. If we want to stretch this money as far as we can to make as much impact, and yeah, simple searches would do that. Otherwise, the truth is we'll revert to using them anyway, or we'll go make our own searches. The dashboard won't be used as much as we want it to be used. So I completely agree with that, actually. If there's a way, please.
Yeah, I'll come in there. I think that's a fantastic idea to raise. So our starting point was we've built the searches for EMIS and System 1. They're all built. There's about 85 of them. The power of CVD Action comes from the integration into the dashboard, for the obvious the reasons that we all understand. But the individual searches are absolutely available. The searches can be uploaded into your system, so that they're available to draw on. Our starting point was not to propose to GPs all across the country, here's 85 searches to use, go forth and transform care, because that's not going to happen, but it's all hyper complex. But you're talking about the sophistication of taking this a stage further. We see what the dashboard shows. Now, what else can we do with that data? I think that's really exciting. So yeah, we could definitely work with you on that. We can absolutely provide the searches ready to upload into System 1 or EMIS. But really keen to then work with you to understand what are you doing with it and how can we share the learning from that too. I think that's very exciting. Steve, did you have anything to add on that?
No, just that I think the only thing to say is that if there are kind of subsearches built, then we should probably we should just, it's difficult for them, to then be able to control what data comes out. So obviously that will be managed locally if there's any amendments or subsearches built beyond that. But yeah, and I think that might answer your question, Yasmin, about how you can use that. You can kind of use accurate stories and that sort of thing, because it'll be in system one at that point, so you can draw all the data you need from that.
Great, thank you. Yeah, so we'll pick up an action then to make those the system level searches available afterwards. One last question in the chat from Yasmin. Matt, if you just want to hang on, because I'm sure you'll be able to answer this as well. Just a question around making local targets available. So specifically for diabetes patients, there's a BP target in North West London that obviously isn't natively on the dashboard. So there's a question of if we could include that.
We'd be really grateful, because North West London have a different target. We're all fighting back to say it doesn't align with actual, national NICE guidelines, but we're not getting very far with it. And we obviously have to meet that target, and also the LDL target is quite strict. And so that diabetes section, I showed it to my diabetes specialist farm, because he was quite excited about it. And ultimately looked at it. I told him about it, actually hasn't seen it as yet himself, and doesn't see the value of him using it if it doesn't give the actual North West London target. So is there something we can do just to blend it together?
Yeah, that's a challenge, because we're building this for every PCN in the country. It's not possible to have that sort of individual local variation. What we've done is to adhere to NICE guidance. So we will absolutely reflect the NICE guidance, that we had to take that principle at the start. And in some areas like North Central London, they've adopted the CVDACTION searches, but sort of built them into their own locally commissioned service and adapted according to their own local guidance. But yeah, I don't think it will help with that specifically, to be honest with you. There may be a small number of areas where it's not aligned with that. It's North West London, isn't it? Do you need to speak to Neville? Does he need to sort that out? Because I agree with you. It should be reflected in those guidance.
We've raised it in different forums, and we're always told it was going to go back to the diabetes team to make a decision. But they're very passionate about their targets and their data, and they're going green in their dashboards. And it's not in. Can't change it. Everyone's tried.
It's a shame.
And if you guys want to try as well, I'll be grateful if you guys come in and say that we're working on hypertension nationally and this target doesn't match NICE guidelines. GPs are getting very confused and very frustrated. Can you change it? I mean, I think all the pressure added on might make a change, but everyone locally has tried.
And maybe Neville trying again. And Neville was on the clinical steer reference group for CVDACTION, so he's been helping to drive the content all the way through. But yeah, I think the challenge of setting up stuff so you can't see wood for trees is a bit of a problem, isn't it? So yeah. So sympathies, but I don't think we wouldn't be able to adapt in that way, unfortunately.
Great, thank you, everyone. And thanks again, Deep and Romil, for sort of offering up your experiences so far. That was all really helpful. I was hoping we could use the final section of this session to just run through a bit of an activity. So sort of listening to the experiences that people have already gone through, and obviously the conversations that we've had following that, I was hoping we could then take some time to do a bit of reflecting in groups, specifically around what your own plans for optimizing high-risk patients might look like, and how you will decide what staff members would be involved. So obviously we've included a few examples here of activities that you might want to undertake for both. So what we'd like to do now is just break everyone into some groups that I think, Jess, hopefully you've been able to sort. That's good, we've got a nod. And we've also got a Miro board, which will include these two questions on it. I think we're just going to drop the link into the chat now. So once you're in the groups, if you just take some time to have a think and have a discussion about what you might want to do locally, and either using examples that you've heard today or thoughts that you've already been having, or conversations that have already gone on to populate the boards. And then so that'll hopefully take sort of 10 minutes, and then we'll come back at the end just to have a look at what's on the Miro, and if that prompts any questions in your groups, then we can address those here as well. So I'll hand over to Jess, who hopefully should be able to pop everyone into rooms shortly. If you were mid-flow, then do you want to pick up what you were talking about and share with the group what your conversations were?
How it's emerging, how we think it's a really useful tool, how we want to really start now getting and developing it, how we have not quite got our pharmacist team to support this together yet, but we were discussing that at yesterday's meeting, the reasons why, and looking forward to going, trying to engage other practices, because one of the practices in our PCN, for some reason or other, won't sign up the data sharing agreement, so they need to be chased and beaten up, really, and publicly humiliated. And
very good. Well, it's good. It's good to hear that you're obviously in the planning phase and you're at the point of kicking off. So that'll be exciting to hear, I think, how it develops as you go. Does anyone else want to offer up any feedback in the last few minutes, or any thoughts at all about the questions you might have? Go on, Kath.
Yeah, so just a very quick feedback from us. I was in the meeting with Fowler, and it was really interesting to hear, but also how beneficial this group is as well. So thank you. It's the first one I've been to. It's really, really useful. And we were just talking about some of the options about how we're going to do that holistic approach and have a variety of different options for people. So, around education, identifying people, because the majority of these people are going to be known to practice, but also are going to be the people that are harder to reach out to and engage with. So looking at what we can offer them out. So it's been a really good discussion, and thank you for that.
Great, thank you for the feedback. Yeah, just on the community practice itself, I think we're very keen to sort of grow this as we go. So we were just discussing sort of future topics and sort of hearing, I think people enjoyed hearing others' actual implementation experience. So we'll be hoping to draw on that in the future, and any specific challenges that we can share. And that, but also if you have ideas and questions that you'd like to bring to the group, then by all means, either let me know directly, or we can have a little standing section at each of the meetings to talk about what we'll address next time. And yeah, hopefully it can sort of be really community led, and it can be a space of shared learning and all that good stuff. Great, brilliant. We've got a minute left then, so I think that's probably a good place to end. We'll keep it at a tight hour today. So thank you very much, everyone, for your time, and we'll catch up in the new year. So happy holidays.
Thank you.
Christmas.
Bye, everyone.
Bye.
Thank you. Bye. Bye-bye.